Okay, so good afternoon, respected judge and participants. So I'm Meghna Kumar and my co-host Chaurjodipto and Navin and our IT help Abhirup will be hosting the event of ophthalmology case history presentation today. First, I'd like to introduce our judge, Dr. Professor Manas Bandyopadhyay, sir. Sir is a professor and head of Department of Ophthalmology at Arjikar Medical College and Hospital. Thank you, sir, for taking out time from your busy schedule to judge this event. I would quickly like to recap the rules. Each participant will get 5 minutes for presentation, after which our judge can cross question on their presentation. Exceeding the time limit will lead to reduction in marks and points, so keep that in mind. And the final results will be announced on 11th at 7 p.m. in the valedictory ceremony. So we shall start. Navin, can you take this forward?
Yes, our first participant is Mr. Sandeep Sarkar. He has now joined the audio, I think.
Sandeep?
Can you hear
Sandeep,
us?
can you hear us? Start with the next participant, Navin. We'll look into Sandeep's then.
Our next participant is Mrs. K. Nandini from Osmania Medical College. Our topic is cataract. You can start now.
Can you hear me?
Yes. Yes, Nandini,
yes,
we
I
can
can
hear
hear you.
You may present your, share your screen basically.
Can you see the screen?
Yes, yes.
Yes.
Okay. Shall I start?
Yes, you may
please.
start.
Okay. Good afternoon, everyone. I am Nandini from Osmania Medical College, here to present a case on cataract. A 62-year-old male who's a daily wage worker by occupation, resident of Hyderabad, belonging to low socio-economic class according to modified Kupuswami's classification, came to the OPD with the chief complaint of diminution of vision in both eyes since 6 months. On further questioning about his complaints, the diminution of vision was found to have a gradual onset, painless, and progressive. Based on this, the differentials could be refractive errors, senile cataract, primary open-angle glaucoma, age-related macular degenerations, diabetic retinopathy, progressive pterygium involving pupillary area, optic atrophy, etc. But both his far and near visions are affected, and the diminution of vision was throughout the day. There is no history of colored halos seen around the white light. And no history of double vision, glare, blunt trauma to eye, use of any oculotoxic drugs, inflammation signs like redness, watering, photophobia, black spots, and frequent changes in glasses. There were no similar complaints in the past and no similar complaints in the other eye. There is no history of any refractive errors and ocular diseases in the past. The patient is known case of diabetes since 6 years and is on treatment for the same. He is not associated with any other comorbidities and no past surgical history. There were no similar complaints in his family and no significant ocular and systemic diseases in the family. His personal history is diet is mixed, appetite is normal, sleep is adequate, bowel and bladder are regular, and he's a tobacco smoker since 20 years. On general examination, the patient is conscious, coherent, and cooperative, moderately built and moderately nourished. No pallor, icterus, clubbing, cyanosis, significant lymphadenopathy, edema. All the vitals and examinations of all the systems is found to be normal. On local examination, head is central in position with no compensatory head tilt. Facial symmetry is maintained. Both uniocular and binocular movements are normal, and forehead wrinkles are present. Visual acuity in the right eye, perception of light and projection of rays is present. In the left eye, 6 by 60 with best correction for far vision. Both the eyeballs are symmetrically placed, and lids and the adnexa are normal in both eyes. Palpebral, bulbar, and phonacial conjunctiva of both eyes is normal. Sclera is white in color in both eyes, and the cornea is normal in both eyes with respect to shape, dimensions, surface, transparency, and sensations. The anterior chamber is normal in terms of depth, and no contents are seen in both eyes. And iris is brown black in color with normal pattern in both eyes. The pupil is single, central, 3 mm in diameter, positioned centrally in both eyes. Direct and indirect light reflexes are present and brisk in both eyes, and accommodation reflex is normal. The lens in the right eye is positioned centrally, chalky white in color, iris shadow is absent, and on slit lamp examination, total cortical cataract with yellow colored nucleus is seen. In left eye, the lens is positioned centrally, dirty gray in color, iris shadow is seen, and on slit lamp examination, gray colored cortex with yellow colored nucleus is seen. After ruling out the other possibilities and based on the significant examination findings and relevant history, the provisional diagnosis is given as mature senile cataract with nuclear sclerosis grade 2 in right eye and immature senile cataract with nuclear sclerosis grade 2 in the left eye. General investigations like BP, RBS, ECG, HIV, and HBS AG are normal. And on applanation tonometry, the IOP of left and right eye are 14 mm Hg each under no anti-glaucomatic medication when measured at 11 a.m. on 22nd February. On gonioscopy, both eyes had wide open angles, and on B scan, echo-free vitreous chamber with normal RCS is seen in both eyes. On A scan, the axial length of right and left eyeballs is 22 mm each, and keratometry findings was right eye 43 and left eye 42. Sorry. Fundus examination, right eye could not be viewed due to cataract, and in the left eye, the medium was hazy, and optic disc was medium size pink in color with CD ratio 0.3:1, AV ratio 2:3, healthy neuroretinal rim, optic disc and vessels normal, foveal reflex present, healthy macula, and background retina normal. As management in right eye, phacoemulsification was done, and PCIO was inserted in the capsular bag. A review was advised next day and after 1 week to check for refraction and early postoperative complications, and after 1 month to check for late postoperative complications. Thank you.
Thank you, Nandini. Hello, can you hear me?
Yes, sir.
Yes, sir.
Okay. Can you please go back to the slides once again?
Yes, sir. Yes.
From the first, yeah. Yeah, please proceed. Just a minute. Go to that examination part. Examination of the eyes.
Yes, sir.
Yeah. Yeah, as you are presenting a case of cataract, so it was quite obvious from the diagnosis that it's cataract. It was a white pupillary reflex, and the age of the patient and the kind of symptom the patient has. What's the importance of the eyelid examination?
Eyelid examination rules out any other possibilities.
Possibilities like?
Corneal opacities, corneal degenerations, which could obscure our view.
But the cornea was clear. I mean, on your subsequent examination, you found the cornea clear. So, I mean, I don't doubt about your diagnosis. Your diagnosis is perfect. But I mean, you examined the eyelid, that's fine. I mean, you did the right thing. But what is the importance of examination of the eyelid in this case? Suppose in a case of cataract, what you are going to treat. So what's the importance of examining the eyelids or the eyelashes for that matter?
For a general ophthalmic case, eyelashes.
Can it, just I'm giving you a clue, can it have any bearing on the outcome of your treatment?
Yes, sir. In the adnexa, if there is conjunctivitis or dacrocystitis or any other conditions present, then...
I'm talking about the eyelids, not the dacrocystitis or conjunctiva.
Blepharitis.
Okay. So if there is blepharitis, then what is the bearing?
Then we have to treat that condition first prior to the surgery.
Why?
Because that could cause iatrogenic endophthalmitis or any infections to the eye after surgery.
Right. Okay. Then how did you examine the eye? I mean, did you examine with a flashlight or did you examine with a street lamp?
For reflexes, I've examined with the flashlight, but slit lamp examination was also done, sir.
Okay. Like, please go to the next slide. Like the anterior chamber. The anterior chamber, you say the depth is normal. So how did you find the depth of anterior chamber?
Using flashlight, I used an oblique illumination from the temporal side and tried to see the depth from forward, from anterior.
So why don't you say that this is a shallow chamber? I mean, what finding did you depend on? That it's not a shallow chamber? You found the depth is normal, fine, absolutely fine. But why this is not shallow? I mean, what did you see actually to negate that this is not a shallow chamber?
The lens was not intumescent, so probably the chamber was not shallow.
No, I mean, you cannot do a back calculation because the chamber, if the chamber is not shallow, then you can say that probably the lens is not intumescent. Whereas otherwise you cannot feel the lens that whether it is intumescent or not. First you have to see whether the anterior chamber is shallow or not. Then you suspect the lens might be intumescent. So you have to know that how do you diagnose the anterior chamber. Okay. Now about the pupillary reflexes, how did you examine the pupillary reaction? You said the direct pupillary reaction is present. How did you see the indirect? What did you mean by indirect reflex?
Indirect reflex is constriction of pupil in the other eye where the light is not shining.
That means you meant consensual reflex. You use the term consensual.
Consensual. Okay.
So how did you measure it? I mean, how did you see it?
The patient was made to sit in a dimly lit room, and obstruction. I mean, I asked the patient to place his thumb over the nose so that the light doesn't go to the other eye.
Actually, we clinicians do not see the consensual reflex like that. Do you know anything about a swinging flashlight test? A procedure called swinging flashlight test?
Yes, sir.
How do you say it?
We shine the light in one eye and rapidly shift that to the other eye.
Right, and we see whether there is any.
Whether if in a normal eye, actually both the pupils will be constricted, and upon shining the light, it will be constricted much tighter.
Right. So what is the importance of seeing the consensual reflex in this case?
To rule out any optic nerve atrophies or optic nerve diseases.
Right, you're right. But what do you say? I mean, what do you call it?
Afferent pathway lesions.
Yeah, it's relative afferent pupillary defect, RAPD. Okay. Fine. Go to the next slide, please. So why do you say this is a cortical cataract?
Because usually shades of white opacities are seen in cortex only. In nucleus, the opacities are yellowish in color. As in the right eye, we can see chalky white in color. So it is probably cortical cataract.
Okay. And you dilated both the pupils, isn't it, afterwards?
Yes, sir.
For your fundus examination. So tell me, what particular thing you should look at the fundus? Because the right eye fundus is not visible because it's a mature cataract. There is no question of seeing the fundus. But in the other eye, that is the left eye, the vision is 6/60. It's an immature cataract, and you could see the fundus also. So what particular thing you should be wary about seeing in that fundus in this case?
Optic disc changes.
Changes for what?
As the patient is diabetic, he could possibly have diabetic retinopathy.
Excellent. Right. The patient was having diabetes, so there was no diabetic retinopathy. That you could mention. That you mentioned various findings. So you could mention that there was no sign of diabetic retinopathy. That would give you. I mean, the examiner would know that you are particularly looking for diabetic retinopathy because the patient was diabetic. Okay, very good. Okay, and can you please show me the picture, the post-operative picture you showed? There is a post-operative after operation. Yeah,
Yes, sir.
that's it. It is it is a picture of acute endophthalmitis, isn't it?
Yes, sir.
So why did you select this picture, acute endophthalmitis? I mean, this case turned into an endophthalmitis.
Actually, this is not the picture of the person, sir. I just kept it for reference.
No, why? I
Because
mean, because this is not the picture of your patient,
yeah,
and your patient did not have this unfortunate incident also,
yeah,
and it's clearly taken from a book or something, because it shows the figure 7.18 or something. So at
yes, sir.
least if you use a picture from a book, at least you could edit it properly.
Uh,
Okay.
Yes.
Yeah. Are you saying anything?
Acute postoperative endophthalmitis is the most deadly complication, sir.
Right.
Because if the person is blinded because of this, then there is no treatment.
I know, but anyway, you don't have to show the feature of endophthalmitis. I mean, this is nothing related to this patient.
Yes,
This patient,
yes.
you said this patient did have a uneventful, uncomplicated outcome, isn't it?
Yes, sir.
Okay, that you said. When you said that the review was on the next day and after 1 week, you didn't
Yes,
find
sir.
anything. I mean,
No.
everything was fine.
Yes, sir. But
Okay. Okay, thank you very much.
thank you, sir.
Okay, can we have the next presentation?
Yes, sir. Our next participant is Mr. Sandeep Sarkar from Bardwan Medical College. His topic is pterygium. Mr. Sandeep?
Hello, am I audible?
Yes.
Yes.
You can share your
Please.
screen now.
Yeah. Is it visible?
Yes.
Yes.
Can I start?
Yes,
please.
you can start.
Okay, yeah. Good morning to one and all present here. My name is Sandeep Sarkar, third professional part 1 from Bardwan Medical College. Today I am here to present a case history on pterygium. So here we have a 46-year-old gentleman, Mr. Shankar Kumar, who is working as a farmer in Baburubag, Bardwan. He belongs to a lower socioeconomic status. This is according to the Kuppuswamy scale. Under the date of admission, 26th August 2020, and date of examination was 27th August 2020. Chief complaints: slowly progressive pink fleshy mass on the nasal side of both the eyes for 3 months. History of present illness: patient was apparently normal 3 months back when he developed a growth in both of his eyes, which was insidious in onset, gradually progressive, causing no difficulty in vision, no associated symptom of pain, diminution of vision, and colored halos. Past ocular history: no history of trauma, squint, lazy eyes, or any other significant past ocular history. No history of usage of spectacles, eye drops, or ocular surgery were observed. Past medical history: no history of diabetes mellitus or hypertension or any other chronic illnesses. No history of medication and allergies. Family history: no significant family history was observed. On examination, general examination, no pallor icterus, cyanosis, clubbing, lymphadenopathy, or edema was observed. Vitals were totally normal. Under the ocular examination, head posture was normal, that is central. No facial asymmetry was observed. Both the eyes were aligned straight, that is orthotropic. Under the ocular examination, visual acuity by the usage of the distant Snellen's chart, which was normal for both the eyes, that is 6/6, and for Jaggers chart, it was for the near vision, it was also normal. And for eyebrows, eyelids, and eyelashes for both the eyes were normal. Under conjunctiva, we observed the vascularized pink fleshy mass on the nasal side of for both the eyes. Under corneal examination, which was done under the bright light, the size, shape, surface, sheen, sensation, transparency for both the eyes were normal. The sclera was also normal. The anterior chamber, no contents were observed in the anterior chamber. Depth was also normal. The iris, the pupil were also normal, and the size of the pupil was normal. Also, the shape was round for both the eyes. Responses to light, the direct reflex and the consensual reflex for both the eyes were present and normal. And also the lens position was normal, and the color, that is, it was totally transparent. Under the lacrimal apparatus, lacrimal punctum skin over the lacrimal sac was normal. Under digital tonometry, fluctuation was present in both the eyes. Under ocular movement, reduction was free and full in all directions. Version was present and normal, vertences were present and normal. Investigation, pterygium can be diagnosed based on the physical examination using a slit lamp. Other investigations may include visual acuity, which was normal in case of my patient, that is 6/6 for both the eyes. Also, corneal topography can also be done, which was normal in my case, in my patient also. And so the differential diagnosis are pseudopterygium, pinguicula, and pterygium. And my provisional diagnosis is stage 1 progressive nasal pterygium of both the eyes. Summary, 45-year-old male patient working as a farmer came with a complaint of growth of pinkish mass in both the eyes. On examination, the eyes were found to have vascularized mass of conjunctival and subconjunctival tissue arising from the nasal side of the bulbar conjunctiva over to the limbus, 1 mm to 2 mm in size from the limbus, stage 1 pterygium, which is progressive in nature. Thank you.
Okay, thank you very much. Could you please go back to the beginning of the slide. Do you think the occupation of the farmer has any bearing on the case?
Yes, sir, farmer.
Yeah. I mean, does it have any bearing on the case on the diagnosis?
Yes, sir. As he's a farmer, he will spend most of his time outside, so he will be exposed to more sunlight as well as dry wind and dust, which will lead to the happening of the pterygium.
Okay. Next one. The next slide, please.
Yes, sir. Yes, sir.
Yeah, please. The next. Proceed, please. Yeah. Okay. The next one. The next one. Yeah. Just stay there. Now, in the conjunctiva, you said that vascularized pink fleshy mass is there on the nasal side in both eyes, and the cornea. You just described the size, shape, surface, sheen, sensation, transparency, everything. But did you mention anything? How much cornea is invaded by the pterygium?
Yes, sir. It is mentioned in my diagnosis as that 1 mm to 2 mm of there is
no, that
from the limbus on the
that you mentioned there. But when you are giving your examination in detail, that is the conjunctiva and cornea, then you didn't mention anything regarding it. In cornea, the findings what you mentioned in your cornea, that everything was normal.
Yes, sir.
But was there any other pathology on the cornea? From this,
no, sir.
From this this slide, where you described your corneal findings, does it show any other pathology on the cornea which the patient had?
Sir. But sir, rather than the pterygium, no other pathologies were there.
But why did you mention that? Why did you mention the pterygium portion in your corneal examination? In cornea, you said cornea examined under bright light, fine, size, shape, everything is normal. Then what is the abnormality on the cornea?
So the abnormality is because we observed it under the bright lights. So because pterygium causes astigmatism, it can't be observed under the bright light. That is a torch light.
Who is it? No, who told you? On torchlight, you can very well see the pterygium, that it has invaded the cornea and how much it has invaded. It may not be very accurate, maybe 1 millimeter or 2 millimeter, but you should have mentioned it. That it has grown about 2 or 3 millimeter. If it is 3 millimeter, it actually 2 millimeters. It doesn't matter at all. But at least you should have mentioned it, that this much a millimeter of cornea is involved by the fleshy mass. That you should have mentioned.
Yes.
Okay. And,
sorry.
Okay, please proceed. The next one. Okay, the next. Next, please. In digital tonometry, oh, just a minute. The earlier one.
Yes.
Yeah. In digital tonometry, you said the fluctuation present. I mean, in digital tonometry, it's merely just to say whether it's a gross estimation of the intraocular pressure, whether it is normal, whether it is grossly increased, or whether it is grossly decreased. So you can say that it's normal, but fluctuation, what do you mean by fluctuation present? Fluctuation can be present if it is hypotonous. If the pressure is high, then also fluctuation can be present. But just you have to judge how much fluctuation is present, whether that fluctuation is normal or not. So we do not describe digital tonometry as fluctuation present. You can merely say it's normal. Okay. And why didn't you take the intraocular pressure when you were presenting a case? Why didn't you take the intraocular pressure by any other means? Only digital tonometry only. You surely must be having access to other modes of tonometry, at least a Shear's tonometry, if not an applanation tonometry.
Yes, Shear's tonometry.
So why did you measure it? Only digital tonometry is not enough. Okay. Then what is the importance of seeing ocular movement in pterygium?
So ocular movement in pterygium, one is before the surgery and one is after the surgery. Both has importance in both the cases. Before the surgery, as pterygium is a fibrosis as well as the elastic degeneration and hyalinization of the connective tissue. So it will pull the eye towards the nasal side. That is, it will cause us a squint, which may cause diplopia.
Okay. I got your point. But from the finding, what you described here, did you expect any ocular movement restriction in this case?
Sir, in my case, it was not present, but it can.
It was not present. But did you? Did you expect to be present in this case?
Yes. Not at all, sir. Because it can be because it is a progressive one. So fibrosis it is not atrophic, it's progressive. So it can be present.
So in your opinion, which kind of pterygium has more likelihood of having a contracture and restriction of movement?
Sir, progressive type of pterygium.
In progressive pterygium?
Yes, sir.
Okay. Then what about the post-operative period? You said the seeing movement in post-operative period is also important. Why is it that?
Yes, sir. This is because that as the pterygium, it is a progressive one. It has vessels in it. Sometimes the surgeon may resect the medial rectus. So it is rare, but sometimes it can happen.
Okay.
So it can cause
okay, accepted. The next one. Next slide.
Yes, sir.
Next slide, please. Yeah.
Yes, sir.
From your picture of the right eye,
yes, sir.
Can you see any? Does it look like a progressive pterygium?
Actually,
the vascularization is very, very less.
Yes, sir. Yes,
in the left eye, you could say.
Yes, sir. Yes, sir.
Okay.
Sir, actually, it is a case of my father. I have seen from front. It's the actual case.
Okay.
So, I have seen it before
okay.
me.
All right. Can in the differential diagnosis, right? In the differential diagnosis,
yes,
why are you mentioning again pterygium? Pterygium is your provisional diagnosis, isn't it?
No. Yes, sir. Yes, sir.
Your provisional diagnosis is pterygium. Then why do you mention again in the differential diagnosis?
Yes, sir. Yeah.
Differential diagnosis means the other possibilities.
Yeah.
So you should not mention pterygium in differential diagnosis. So how do you? How do you differentiate from a pseudopterygium? Why this is not a pseudopterygium?
Yes, sir. Yes, sir. In order to differentiate it from pseudopterygium, first of all, pseudopterygium can occur in any place of the conjunctiva. That is, it can be palpebral bulbar conjunctiva, and pterygium is only limited to the palpebral fissure or the bulbar conjunctiva, and most commonly it is nasal. Secondly, pterygium is a degenerative process, and pseudopterygium is an inflammatory condition.
That you cannot see. That you cannot see whether it is degenerative process or inflammatory process. but you have to
Okay.
have some history.
Yes, sir.
Is there any
Yes,
procedure
sir.
by which you can differentiate?
Yes, sir. Probe test, sir. Probe test.
Okay, how do you do it?
Sir, in the case of pterygium, a probe cannot be passed below a pterygium, but in the case of the pseudopterygium, a probe can be passed below it. So in this way, probe test is negative in the case of the pterygium and positive in the case of the pseudopterygium.
Okay, can you tell me what is the first step in a probe test? The first thing you should do in a probe test?
First thing, sir, we need to elevate the pterygium from its neck, and then we can look and insert a probe. Like, is it going through, like, passing under the pterygium or not?
You just imagine the real scenario. Okay, the first thing you should do. The patient is lying down on the table. The first thing you should do in a probe test. What is that? Imagine the real scenario.
Sir,
you don't have to anesthetize the conjunctiva. Without anesthetization,
yes,
pass the probe.
Yes, sir. We have to anesthetize. Otherwise, the pain, yes, sir, it will cause pain to the patient.
All right. Did you mention anything regarding the treatment of this pterygium?
So not in the case actually. So not in my presentation.
Oh, you didn't mention anything in the treatment here. Okay, so what treatment should you do in this case?
So, sir, if it is a initial case, pterygium can cause
not what you can do. What you will do. In this, this is a case, and what you will do in this case. The patient has come to you for cosmetic reason, isn't it? Because it is unsightly, that's why the patient is
progressive. Okay, sir. Yeah, as this is a progressive pterygium, so we can do for surgical excision. Under the surgical excision, the most commonly which is done is this is perfect surgery.
No, just a minute. I'm not asking you a theoretical question that what are the options in a pterygium for a treatment of pterygium. I'm asking you based on this case only. This is a practical question, and on this patient, what should you do? So there can be only one option. We can do this, we can do that. It cannot be an answer like this. In this case, what should you do?
Sir, we will do CLAG, conjunctival limbal autograph, because this is a cosmetic defect as well as a progressive one. So we will go for the CLAG.
From where will you take the conjunctival graft?
Sir, from the upper conjunctival, just above the cornea, upper part of the bulbar conjunctiva.
Okay.
Along with the limbus.
Okay. Okay. Thank you very much.
Thank you, sir.
You can proceed to the next one.
Yes, sir. Our last participant is Mrs. Priyankshi Maurya from AFMC. Our topic is glaucoma.
Hello, am I audible?
Yes.
Yes.
Good afternoon,
you can
sir.
share your screen.
Yeah, right. Is it visible?
Yes, please.
Good afternoon, sir. Good afternoon, everyone. I'm Priyankshi Maurya from AFMC. I'll be presenting the case of a 47-year-old female, Mrs. ABC, housewife by occupation, hailing from Shaniwarpet, Pune. She has studied till 12th standard and socioeconomic status class 3. She was examined on 8th of March 2020. Chief complaint: patient presented with painless diminution of vision in right eye since 10 months. History of presenting illness: patient was apparently asymptomatic 10 months back, after which she noticed diminution of vision in her right eye. It was insidious in onset and gradual in progression, not associated with pain. She experiences difficulty in doing near work. There is a history of frequent change of spectacles in the last 10 months. She also gives history of repeated episodes of redness, watering of eyes, and mild headaches in last 10 months. There is no history of image distortion, photophobia or glare, night blindness, nausea or vomiting, transient visual loss, trauma to the eye or head,
colored halos, black spots. Past ocular history. Patient was prescribed reading glasses when she was 45 years old. At that time, patient's power was plus 0.5, and which has now increased to plus 2. There is no history of ocular surgeries or use of eye drops. Past medical history. There is no history of diabetes mellitus, heart disease, asthma, hypertension, or any other chronic illness. No history of herpetic keratitis. There's no history of allergy to any food or drug. Family history. Patient's late mother had lost her sight in her left eye at 50 years of age. The cause was not known. Patient has one son and one daughter. Both are in good health. Personal history, diet mixed, appetite normal, sleep adequate, bowel and bladder habits regular, no addictions. General physical examination. Patient aged 47 years is conscious, cooperative, well oriented to time, place, and person. Patient is examined in a well lit room after taking informed consent. Height 163 centimeter, weight 70 kgs. BMI came out to be 26.3 kg per square meter. No pallor, icterus, cyanosis, or clubbing. No lymphadenopathy or edema. Vitals were in normal range. No sign of nutritional deficiency. Systemic examination were normal. No significant findings were present. Ocular examination, head posture normal, facial symmetry present, ocular symmetry present. Presenting the right eye first, visual acuity, patient was able to count fingers at 3 meter, near vision was not checked, eyebrows normal, orbital margins normal, ocular movements free and full in all directions, eyelids normal, palpebral aperture normal, 26 mm in width and 10 mm in height, lacrimal puncta was normal and skin over lacrimal sac was normal. Roplast test was negative. Eyelashes and conjunctiva normal. Sclera normal and white in color. Cornea clear and lustrous, normal in size, shape, surface, and sensation. Anterior chamber normal in depth and optically clear. Iris normal in color and pattern. Pupil round and regular. Pupillary reactions were present. Lens normal in position and color. IOP was measured by applanation tonometer and it came out to be 25 millimeter of mercury. Oblique flashlight test was done in which whole iris illuminated uniformly and crescent was absent. Fundus examination, media normal, cuppus to disc ratio 0.8, color of disc pale, neuroretinal rim showed inferior and superior thinning, blood vessels showed nasal shifting, macula is normal. Now left eye is normal except the IOP of left eye came out to be 2 millimeter of mercury. Otherwise, the left eye was normal. Summary. This is a case of 47-year-old female presenting with the complaint of painless diminution of vision in her right eye. On examination, her right eye was found to have increased IOP and glaucomatous changes of fundus. In her left eye also increased IOP is present, but no glaucomatous changes were seen. Provisional diagnosis, primary open angle glaucoma in right eye and ocular hypertension in left eye. Differential diagnosis of painless gradual loss of vision. It can be cataract, diabetic retinopathy, corneal degeneration, pterygium, age-related macular degeneration, refractive errors, retinitis pigmentosa, and optic nerve compression. Further investigations, corneal central thickness, central corneal thickness, diurnal variation test, perimetry and provocative tests, and nerve fiber layer analyzer. Thank you, sir.
Thank you. Could you please go back to at your beginning? Okay, this patient's age is 47 years.
Yes, sir.
And you diagnosed it as a primary open-angle glaucoma.
Yes, sir.
So, how did you say that this is a primary open-angle glaucoma? What are the points in favor of your diagnosis?
So first of all, her chief complaint was painless diminution of vision.
Okay, just a minute. Is dimness of vision is a prominent symptom in primary open-angle glaucoma?
Sorry, sir?
Is dimness of vision a prominent symptom in primary open-angle glaucoma?
So diminution of vision occurs in late disease.
It occurs quite late.
Yes, sir.
It's an advanced glaucoma when there is a wipeout of the macular central vision also.
Yes, sir.
So do you think the patient has reached at that stage? Because the other eye you said is normal. Your
Yes,
fundus examination is normal.
Yes, sir.
This is okay, that we will come later. But the patient is also 47 years of age.
Yes,
And what is the usual age for an advanced glaucoma? A person having an advanced glaucoma, what is the usual age?
so
What is the
50,
usual age of having open angle glaucoma, primary open angle glaucoma?
so 50, 55.
Yeah, it's usually above 50. If not, okay, if it is, if the age is above 40, definitely you can suspect glaucoma. But
Yes.
47 is quite early age to have an advanced glaucoma. Okay. And it's very, very unlikely that this patient has dimness of vision because of glaucoma only. And you did not do any perimetry in your investigation. You did not do any perimetry also.
No, sir.
So you never know that how much field was damaged in this case. So to brand it as an advanced glaucoma, only based on the disc finding, just 0.8 cupping, would be a little difficult. And you didn't draw any picture of your disc also. Just when you are describing the disc of a glaucoma patient, you should always give a drawing that how does it look like? How are the neuroretinal rim? Where is it thinned? Where, I mean, you describe this, the nasal shifting. You should draw it in a diagram. If you do not give a fundus photograph, fine. Okay, then in the left eye, you said that everything is normal in the fundus disc.
Yes.
Everything is there is nothing called a normal disc. Okay, you have to describe the finding. Like when you are saying that the CD ratio, the vertical cup disc ratio is 0.8. So you didn't mention anything regarding the vertical cup disc ratio in the left eye. How was it?
So it was a normal range, 0.3, 0.4.
No, that means either you didn't see it, or you don't know the importance of having mentioning a CD ratio in the other eye. Because then if you have to mention it as primary glaucoma, then what is the I mean, how much difference should be there between the two eyes?
So 5 millimeter mercury.
5? No. I'm talking about the vertical cup disc ratio, VCDR. What you mentioned, the 0.8 in the right eye.
So 0.2 to 0.3.
So it's more than 0.2. That is pathological. Okay.
Yes,
So
sir.
here, that's why mentioning the vertical cup disc ratio was very, very important in this case, which you merely just mentioned as normal. So definitely you have to mention that what was the vertical cup disc ratio.
Yes, sir.
And the other findings. And you diagnosed it as the ocular hypertension in primary open angle glaucoma in one eye and ocular hypertension in the other eye. Isn't it?
Yes, sir.
In your diagnosis. But diagnosis cannot be a primary open angle glaucoma in one eye and ocular hypertension in the other eye. Ocular hypertension is it's an overall diagnosis, and primary open angle glaucoma is an overall. Either the patient is suffering from primary open angle glaucoma, or the patient is suffering from ocular hypertension. How did you diagnose ocular hypertension in the left eye?
So the IOP of the left eye, it was 22 millimeter of mercury.
Only. Then what else? The disc you said normal, though you have to mention that the fidelity ratio, and you didn't do any field also.
Yes,
so unless you do a visual field, how do you know that there can be a visual field defect? Unless the patient does not have any field defect, have an absolutely normal disc, and only high intraocular pressure, where it is just borderline, it's 22. I mean, the statistics is the range is 10 to 21, this is just 22.
Yes.
And as you do not mention the visual field abnormality, so it will be difficult to brand it as a ocular hypertension. So if the patient is having a glaucomatous change in one eye, then you have to brand the patient as glaucoma only, not ocular hypertension. Now, whether it is primary open angle glaucoma or not, that is a separate question.
Yes, sir.
So it cannot be ocular hypertension.
Yes, sir.
So on the examination, would you please go to the examination part? Yeah. The next one. The next one. Yeah, please here. The iris pupil anterior chamber is normal in depth and optically clear. Then next one. Yeah. IOP, did you examine IOP by which method?
So Goldman's tonometer.
Goldman
Addition.
tonometer.
Yes.
Okay. And you didn't do any gonioscopy?
No, sir. Actually, I did oblique flashlight test to look for angle, if the angle is closed. Or
You cannot see angle is closed or open by just by an oblique flashlight test. An oblique flashlight test can only give you an idea whether the anterior chamber is shallow or anterior chamber is normal or deep.
okay, sir.
Okay. But if you have to diagnose a primary open angle glaucoma, if you have to say that angle is open, then definitely you should do a gonioscopy.
Okay, sir.
Or if you do not have a gonioscope, then at least you can see with a slit lamp. By which method? Do you know any other method by which even without a gonioscope you can have an idea whether the angle is amenable to closure or angle is unlikely to close? There is a gross method, though it is not very foolproof, but there is a method. Do you hear something about Van Herrick method?
Van Herrick.
Yeah. At least that as you have examined in slit lamp, at least you should have mentioned Van Herrick method just to see whether this angle is amenable to closure or angle is unlikely to close.
Yes.
So that also you didn't mention. And when you are presenting a case of glaucoma, you have to have a gonioscope, gonioscopic finding. Okay.
Yes.
Then would you please come to the differential diagnosis, where you mentioned the list of differential diagnoses like cataract. There is no cataract. Okay. And in the left eye also, the vision is only 6 meters, isn't it?
So more than 6 meters.
There is nothing. Couldn't you measure it? What is meant by more than 6 meters? If my vision is 6, if my vision is 6 by 6,
yes, sir.
then it is also more than 6 meters. But if it is 6 by 24, it is also more than 6 meters. Then how do you say? I mean, how do you measure the vision in the left eye?
So I did bedside far vision test, like counting fingers. So she was able to count finger at more than...
No. You cannot do that in a case presentation.
Yes, sir.
When you didn't, I mean, you examine in a slit lamp. Okay, because isn't it?
Yes.
How did you take the intraocular pressure? You say by Goldman applanation tonometry. When you say that you examine with Goldman applanation tonometry, that means you examine the patient in a slit lamp. You cannot do that just by bedside.
Yes, sir.
So the problem is, if you make up everything, then it will be very difficult to corroborate. Okay.
Yes.
At least the vision you should have mentioned for the left eye. Then what do you think? Why do you think the vision is so poor in this case? Okay, I accept that the patient is having an advanced glaucoma, and that's why maybe the central vision is involved, and that's why the vision is so poor in the right eye. But what about the left eye? The left eye, everything you found normal, and still the vision is only 6 meters. Or you are saying that beyond 6 meters, and better than 6 meters. Now, why this is not a retinitis pigmentosa? You wrote retinitis pigmentosa in your differential diagnosis.
So there was no history of night blindness.
So retinitis, does retinitis pigmentosa present like this? That dimness of vision for last 6 months?
So there is gradual dimness or diminution of vision.
In retinitis pigmentosa, why there is a dimness of vision in retinitis pigmentosa? Do you think? What are the causes?
So the retina,
retina is involved. That's why. But when the macula is involved in retinitis pigmentosa, does it affect very early or does it affect quite late?
I don't know.
Okay. Okay. Thank you very much.
Thank you, sir.
Thank you. Hello?
Hello,
Yeah,
am I
yeah.
audible?
Yeah, you're audible, and
Uh,
I think we are finished.
yes, sir, we are finished. So, thank you to all the participants for sharing your wonderful presentations. Thank you to sir for sharing your valuable inputs on those. I'm sure all of us here have learned something, a little something more about the eye. Uh, Sir, I would request you to say a few words to our audience and to the participants.
Okay. So thank you very much for presenting these three nice presentations. At least you tried very well. So obviously there would be some lapses which you are bound to commit that because you are students. And but overall, the presentations were quite nice. The slides were good, and I wish you all success.
Thank you, sir.
Thank you, sir.
Thank you, sir. A note to all the participants, we will not be declaring the results now. The results will be declared on 11th at 7 p.m. at our prize distribution ceremony. Till then, best of luck.
I just request everyone to switch on their cameras once for the screenshot. Aviru, can you take a screenshot? Avirup, is it done? All right, then we'll be ending the session now. Thanks a lot, sir.
Thank you very much.
Thank you, sir.
Bye.